Today we are going to discuss the recall questions. So these are the questions that were related to infectious diseases in the recent NEET SS entrance exams. And most questions are based on recalls. So while the questions may be entirely correct, there might be some issues with the options. We don't have the options for all the questions, but we'll try to give you an overview of the kind of questions as well as the best possible answers for them. So coming to our first question, they had four options which which did not include antibiotics, but tendon rupture is caused by. So if we look at tendinitis or toxic tendinopathies caused by drugs, so these are the four main categories of drugs that are related with toxic tendinopathies. That is fluoroquinolones, aromatase inhibitors, glucocorticoids, and statins. Now, we did not have the other three options except for the statins. So the answer here is statins. And if we look at the special characteristics of the tendinopathies associated with these drugs, you'll see that except for aromatase inhibitors, all of these drugs cause tendinosis. And what's tendinosis? Tendinosis is progressive degeneration in the absence of inflammation. Whereas the kind of tendinopathy with aromatase inhibitors is associated with inflammation. So the answer to this question is statins. Had there been an antibiotic in this question, then it would have been fluoroquinolones. Coming to next question. So Van Wert syndrome, this was something that we did not discuss in our classes, but it's an interesting syndrome which is associated with Lyme's disease actually. So what is Van Wert syndrome? It's actually lymphocytic meningoradiculitis. So it has two parts. So there is a radiculitis as well as meningitis, and the meningitis is lymphocyte predominant. It is seen in early Lyme's disease, and it is more commonly described in Europe and Asia. So it starts as radicular pain and then leads to CSF pleocytosis that looks like meningitis. And it is one of the rare differentials of chronic meningitis, actually. So since this is a part of Lyme's disease, and we know Lyme's disease is caused by Borrelia burgdorferi, so the right answer over here is Borrelia burgdorferi. Coming to the next question. So this is an interesting question. So an intern who is unvaccinated for hepatitis B has been posted in the department. And as you all know, like healthcare workers are supposed to get vaccinated. It's a very, it's not a addressed topic, especially in our settings, but healthcare workers should be vaccinated with appropriate vaccines, especially in today's date and time. The COVID vaccination should be up to date. Hepatitis B vaccination for sure for your own protection, and influenza vaccines. Apart from that, age-appropriate vaccination as per the guidelines, but these are some recommendations, some vaccines that you should definitely be vaccinated. So the question here is different. So the consultant, of course, asks the interns to get an accelerated Hep B vaccination. At what time will he have to take the vaccine? Now, the question is kind of vague. Why is it vague? So we'll just understand it in the next few slides. So if we just look at the most recent update for the adult immunization schedule, if you look at hepatitis B, then you see that there's a variable recommendation. It says 2 or 3 or 4 doses, depending on vaccine and condition. So we'll see what are the vaccines and conditions. And even if you see the recommendations as per the conditions, except for pregnancy, it again says 2, 3, or 4 doses, but for pregnancy, it just says 3 doses, right? So for hepatitis B, there are different or varying vaccination schedules, and it depends on the type of vaccine that is being used. So if you look at the commonly available vaccines, it's Heplisav B, Engerix B or Recombivax, and Twinrix. Now, For pregnancy, Hepatitis B is not approved, as in there are not many studies to document safety of the vaccine. So that's why the 2-dose vaccination schedule is not mentioned for pregnant patients. Otherwise, you just do 2 doses, 4 weeks apart. That's Hepatitis B. The most common dosing schedule that is used is Engerix B or the Recombivax Hep B, which is 3 doses at 0, 1 month, and 6 months. So that is the most common vaccination schedule. Now, the other option with the same vaccination schedule is Twinrix. So if you're doing the routine 3 doses, it's 0, 1, and 6 months. That's very clear. Now comes to the accelerated or the 4-dose schedules. Now, typically the accelerated schedule is where you finish the first 3 doses within 1 or 2 months, and that is followed by a booster 6 to 12 months later. So if we look at the first one, Twinrix, so this is where you, for the Twinrix, you complete the first 3 doses within 1 month. So it's 0, 7 days, and 21 to 30 days, followed by a booster at 12 months. And the Engerix B 4-dose schedule is, in this, the first 3 doses are given within 2 months. So it is 0, 1, and 2 months, and the 4th dose is given at 6 months. Now, the Engerix B 4-dose schedule is also commonly used in patients with on hemodialysis, and they use a double dose vaccination because the immunogenicity or the immune response in dialysis patient is poor. So like we see, the Twinrix accelerated schedule, it's 0, 7. The 3rd dose will be between 21 to 30 days. It could be 3 weeks or 4 weeks. And then a booster at 12 months. So the answer, the best possible answer over here is 0, 7, 28 and booster at 1 year. What is wrong with this choice? So where the booster is at 6 months, the first 3 doses will be 0, 1, and 2 months. So this is about the Hepatitis B vaccination. Coming to another very simple case scenario that we have already discussed in our classes or topic reviews. So a 59-year-old male, history suggestive of acute lower respiratory tract infection. I'm sure some data was given with respect to the blood parameters, blood pressure, etc., with a TLC of 13,000, and it just asks about the type of management. Now, we've already discussed the same slide in our topic reviews where you can use either the CURB-65 or the pneumonia severity index. Now, in this question, they just wanted to assess the CURB-65, and the patient actually had 0 score. So if we look at the age, rest parameters normal, TLC is not taken into account in CURB-65, and with a CURB-65 of 0 or 1, you can just do a outpatient care for this patient. So ambulatory care for CURB-65 of 0 and 1. So a relatively very simple question with respect to community-acquired pneumonia. Next, so Mollaret meningitis is caused by. Now, again, this is something that we have already discussed in our topic reviews where while discussing meningitis, amongst the causes of meningitis, we had talked about Mollaret's meningitis specifically as a potential question. So what is Mollaret's meningitis? It's a form of benign recurrent aseptic meningitis that is almost always due to herpes simplex 2 infection. However, it does not mean that if the HSV2 PCR is negative, then it cannot be Mollaret's meningitis because you may not be able to detect it by the time patient comes to you, right? So it's a benign recurrent aseptic meningitis. And also, like we know, HSV2 is more associated with genital lesions, but by the time patients usually present, they are absent. So just briefly going through again the causes of meningitis, we have done this in details. Most common is strep pneumonia, followed by Neisseria meningitidis, and then extremes of ages, pregnancy, Listeria monocytogenes, and then these are the list of meningitis-causing pathogens covering all spectrum, common clinical features. So we had already talked about Mollaret's meningitis in very brief, like just like a one-liner MCQ. just like it has appeared in the exam, and HSV2 is the cause. So again, to revise, it's a recurrent episodes of fever and meningismus. Episodes demonstrate CSF pleocytosis. Episodes are followed by symptom-free periods that last weeks or months, and there are no sequelae or lingering symptoms following resolution of the episode. So these are the characteristics of Mollaret's meningitis, and it might be quite a challenge to actually diagnose these. So these things are relatively simple to read and understand, but really in real life scenario, when patients really come to you, you have to have a very high index of suspicion for such cases. Next question. Again, this is something that we have discussed during our topic reviews. I'm happy that like these questions were asked. False statement about Leptospira. Of course, the majority of infections are not fatal in nature. So like when we had discussed about Leptospirosis, the mild anecteric disease is the most common presentation. In fact, in a majority of patients, it is so mild that it might even go unnoticed. So the false statement is that the majority of infections are fatal in nature. So the right statement is majority of infections are mild in nature. Except for that, all the other options are correct. Classical finding in Leptospira nephropathy. Now, this is the exact one point that we did not cover in the class. And like, unfortunately, this is the only thing that was asked. It's a line from Harrison's textbook, and somehow the examiners, try to throw a googly every now and then. So we had discussed about clues to diagnosis. We talked about leukocytosis, thrombocytopenia, hyponatremia, hypokalemia. So hyperbilirubinemia, transaminitis, etc. This is the point that we had missed, and this is what was asked in the exam. And of course, there's renal dysfunction with casts, RBCs, and urine. Apart from loss of magnesium in urine, the other electrolyte abnormality is hyponatremia and hypokalemia. So you will see that the other options were hypernatremia, hypokalemia, which were wrong. Hypercalcemia is also not seen. So it's mostly a loss of things. So loss of magnesium. So this is something like we can keep in mind for if it is ever asked again. Next question, again, this was covered in our topic reviews, and the question was larva occurrence is due to. So it's because of Strongyloides stercoralis. And so basically, both larva occurrence and cutaneous larva migrans are, worms wriggling through your skin or under your skin. The differentiation between larva occurrence and CLM is based on the rate of progression. Larva occurrence is quite, fast. It's a few centimeters every hour, and it's mostly seen in the perianal region, thighs, or trunks. Whereas cutaneous larva migrans, which is caused by these agents that are listed here, they're mostly seen in the extremities. That's the point of entry of the worms. And that these are animal hookworms that cause cutaneous larva migrans. Only occasionally the human hookworms can cause cutaneous larva migrans. So larva occurrence, Strongyloides stercoralis. We have discussed strongyloids in details. You might want to go back and revise the entire topic. Next question, interesting question, ganciclovir resistant CMV infection treatment. Again, something that we have covered in details. So going back to those slides, what are the mutations associated with drug resistance in CMV? So UL97 mutation is associated with ganciclovir resistance, 54 with almost all drugs. So ganciclovir, foscarnet, cidofovir, although does not affect the new drugs like letermovir and maribavir. But if we look at letermovir resistance, it's UL56, 51, and 89. So these are the things that you have to mug up. Now, the important thing in clinical practice is only this much information is not useful. So they also give you the codons at which the mutations occur. And then you have to actually search the database which is available online to see what kind of resistance, whether it's a high level resistance or a low level resistance. So that depends. There's no way of memorizing all the mutations of the codons, but yes, more or less you can remember which mutations, like which ultra long regions in the genetic makeup mutations are associated with drug resistance. The next important thing is UL97 kinase mutations. So UL97 mutations can lead to both ganciclovir resistance and maribavir resistance, but both the mutations are kind of different. They affect the different areas of the UL97. Management, most important point is reduction in immunosuppression wherever possible. If it's a low level resistance to ganciclovir, you can actually try high dose IV ganciclovir. Alternative therapy is foscarnet or cidofovir, depending on the mutations. Of course, other therapies like CMV specific immunoglobulins and CMV specific T cells, these can also help in management. So I was just, this week we were just seeing one patient with CMV resistance. I would just like to share the resistance profile. So here you can see that the resistant mutation that was detected was UL97 and the codon was C480F. And in the bracket, they say ganciclovir and maribavir resistance. So it's UL97, but what matters is the codon number. So there's again no way of memorizing it. If you can mark it up, it's fine. If you cannot, clinically, you are never expected to, remember these things. You can always look it up. What you can remember is these 4 or 5 mutations associated with CMV resistance. So the answer here is foscarnet. Of course, these questions can be even made more trickier, like I said, with you can have more than one options correct. If the options included reduction of immunosuppression, and if they talked about low-level ganciclovir resistance, then high-dose ganciclovir could have been an option. But for simplicity's sake, the alternative to ganciclovir-resistant CMV is foscarnet for all practical purposes. Next question, indications for steroids in PCP pneumonia. Again, it's PCP or PJP. It's called Pneumocystis jirovecii pneumonia and not Pneumocystis carni after the change in nomenclature. Anyway, this is again something that we have discussed. So if we go back to our discussions from the classes, you see that we had classified Pneumocystis pneumonia based on the hypoxia. So if the PaO2 was greater than 70 or the A gradient was less than 35, it was mild, and by default PaO2 less than 70, and then depending on the A gradient, it was divided into moderate or severe disease. Next, if we look at the treatment, for moderate to severe disease, we have discussed it's IV Cetran and adjunctive corticosteroids. So moderate to severe disease is the indication for adjunctive corticosteroids in Pneumocystis pneumonia. For mild disease, it does not require adjunctive corticosteroids, and you can even try the per-oral Cetera instead of IV Cetera. So going back to the question, PaO2 less than 70, which means moderate to severe disease. We don't know the A gradient, so we don't know if it's moderate or severe, but definitely indication for steroids. Again, this is something that I had emphasized upon a lot when we were discussing the anaerobic infections. We have a comprehensive review of non-difficile clostridial infection, where we discuss botulism, tetanus, gas gangrene, etc. And the diagnosis of tetanus is always clinical. So no other investigations actually help in diagnosing tetanus. If you're suspecting tetanus, it's possibly tetanus. The only important thing is, say for example, you're in doubt whether it's tetanus or not, and if you have antibody testing available, so the only role of antibody testing would be if the antibody test is positive at presentation, that can actually exclude the diagnosis of tetanus. Otherwise, it's a clinical diagnosis. Next, another very important question. So to prevent hepatitis B reactivation, in a patient having rituximab treatment, how many months of HBV prophylaxis is given. Now, this brings us to an important concept of prevention of hepatitis B reactivation. So just we look at the algorithm as to how and when do we actually, suggest prophylactic treatment for hepatitis B reactivation. So if you say a patient is about to receive a immunosuppressive regimen, then you have to screen for both hepatitis B surface antigen as well as hepatitis B core antibodies. So anti-HBC and HB surface antigen. Now, how do you interpret? Now, if both are negative, which means the patient was never infected, then you can actually vaccinate the patient. Now, it depends. If the patient is already vaccinated, the anti-HBS will be positive, so you don't need to do anything. If the anti-HBS is negative, definitely you can vaccinate the patient. But there's no indication or need to put this patient on any preventive treatment except for vaccination. Now we have two groups. In both the groups, the core antibodies are positive. In one group, the surface antigen is negative, and in the other group, surface antigen is positive. So if the surface antigen is positive, as you know, it would just become chronic hepatitis B. And in these patients, even if the indication to start antivirals is not met as per the hepatitis B treatment guidelines, you will start antiviral prophylaxis. Now coming to this group, which is in between, so there the surface antigen is negative, but the anti-core antibodies are positive, which means the patient had hepatitis B in the past, but has cleared the surface antigen, right? Now you have to see whether it's a moderate risk immunosuppressive or a high risk immunosuppressive. Now, there are multiple societies that have given guidelines with respect to this. The moderate risk immunosuppression is only defined by the AGA guidelines, like the American Gastroenterology Association guidelines. Otherwise, most guidelines just take into account high risk immunosuppression. That is usually the anti-CD20 antibodies like rituximab. Now, in these patients, if you're giving high risk immunosuppressive therapy, you have to start antiviral prophylaxis. However, if you're doing a moderate risk immunosuppressive therapy, you can either choose to start antiviral prophylaxis or just choose to monitor every 1 to 3 months. And if there's a Hep B reactivation, you can start antivirals. So the most important point is you have to check both core antibodies as well as surface antigen. If both are positive, you start antivirals. If surface antigen is negative and core antibody is positive, then if you're doing a high risk immunosuppression, then you start antiviral prophylaxis. So there's no confusion related to this. If you're not doing a high risk immunosuppressive therapy, it's up to you. You can either do monitoring or you can even start the antiviral prophylaxis. Now, coming back to the question is about the duration of treatment or duration of prophylaxis after stopping the immunosuppressive therapy. So if we look at the summary of all the recommendation, the ASLD, APASL, AGA, and ESL, so you will see, like I mentioned, first of all, you'll see that most guidelines just talk about rituximab in general, except for the AGA, where they talk about high risk and moderate risk. And in the moderate risk, they have taken TNF alpha, cytokine inhibitors, integrin inhibitors, tyrosine kinase inhibitors, and even low-dose corticosteroids, where they say prophylaxis is preferred, but can consider on-demand therapy. So that's a subjective thing. But otherwise, for high risk, prophylaxis is always recommended, right? And in addition to B-cell depleting therapy, what other agents are considered high risk? Anthracyclines and moderate dose corticosteroids for more than equal to 4 weeks. So in these cases, you will do prophylaxis. So what are the options available for prophylaxis? You can do entecavir or tenofovir, right? Either of the two. And among tenofovir, you can do any of the formulations like the disproxil or the alafenamide. Both are fine. Now, the duration of prophylaxis. So this says 6 to 12 months after immunosuppression. So if you're given rituximab, you've completed rituximab, then you continued for 6 to 12 months. So there is some agreement between most guidelines. You'll see it's 6 to 12 months to 12 months, right? So that is, now coming back to the question, so it will be 6 to 12 months after stopping, right? So this is an important concept though to cover. Next question, again a deja vu moment. A patient with diplopia, dysphagia, dysarthria started having weakness in both upper limbs. 12 hours later, had respiratory distress and needs mechanical ventilation. So if you remember, this is a similar kind of case that we have already discussed, right? So the case we had discussed was 43 female, no comorbidities, presented with GI symptoms, then had blurred visions that default over 48 hours. There's no history of fever, seizures, altered sensorium, now developed urinary retention, ptosis, upper limb weakness, and respiratory distress. So this is exactly similar scenario, and the hint to this was canned foods, ptosis, and it's also seen in children, with the practice of feeding honey, where it can lead to infant botulism. So the answer over here is botulism due to the botulinum toxin. Why it's not diphtheria, or like diphtheria can also present with neurological complications that involve the cranial nerves and can even cause neuropathies and paralysis like presentation, but it's rare and it's only seen in very severe cases of diphtheria. It starts as local neuropathies like paralysis of the soft palate, posterior pharyngeal wall, and then there could be cranial neuropathies. And the peripheral neuritis actually takes weeks to months to develop. So in this question, actually things had progressed very fast. So this was most compatible with botulism. Next question. This is a question that is completely fact based. There's nothing to. I mean, there's a lot to understand, but it's not worth it. You can actually just remember the types or the numbers of TLRs and also the common ligands for these TLRs. Just coming to basics, what are TLRs? These are basically, the full form is toll-like receptors. They are family of receptors that constitute the first line of defense. So they can recognize both invading pathogens and endogenous danger molecules. So PAMPs and DAMPs, pathogen-associated molecular patterns and danger-associated molecular patterns, something like that. The basic concept is these are receptors that are present on cells. Some of them are on the cell membrane, some of them are intracellular. Basically, whenever they bind these PAMPs and DAMPs, it leads to activation of a cascade, which the most common molecules are NF, kappa, beta, AP1, IRF. So these are the common ones that actually then lead to production of inflammatory cytokines and even interferons. So these actually form the first line of defense, activation of innate immunity, as well as it eventually leads to recruitment of lymphocytes that leads to your adaptive immunity eventually. So if we look at the number of toll-like receptors, they're usually 9. 5 of them are on the surface and 4 are intracellular. And if we look at the ligands for all these receptors, you can just kind of memorize things. For the intracellular receptors, it's mostly the nucleic acids, ribonucleic acids or DNA, and CpG DNA for TLR9, single-stranded RNA for TLR7 and 8, and double-stranded RNA for TLR3. But what was the question? Question was what binds to TLR5? So that's flagellin. So the answer is going to be flagellin. You can try and remember other things, especially say TLR4, 5, and these intracellular ones. And the rest you can, try and exclude from the options if at all you come across a similar question again. So the answer is flagellin. Which of the following is not an extrahepatic manifestation of hepatitis C? Again, so there's a long list of extrahepatic manifestations of hepatitis C. And if you look at the list, it's exhaustive. The important thing to notice here is it is associated with a non-Hodgkin's lymphoma, where the options mentioned Hodgkin's lymphoma. So apart from that, it is associated with everything else that's mentioned in the question. So the answer is going to be Hodgkin's lymphoma because Hep C is associated with non-Hodgkin's lymphoma. Just to complete the discussion, these are the common infectious agents that are associated with certain malignancies. You can try and remember these. They're not very difficult to remember. Most of them you would be knowing anyway. There's just a single screenshot for having it handy. It's from Harrison directly. So the answer is B cell Hodgkin's lymphoma. That is not usually or not an extrahepatic manifestation of hepatitis C. Next question. Again, something we have already discussed. We tried to discuss malaria in great details. It's a separate topic in the schedule. So the question is about a pregnant female in a first trimester, peripheral smear showing multiple ring forms suggestive of falciparum, and the question is regarding drug of choice. So just going back to the slides that we had discussed already. So P. falciparum malaria in first trimester, our recommendation was 7 days of quinine plus clindamycin. So the answer is quinine. But again, I would like to just highlight this thing that this is from the WHO guidelines directly, that adults and children with severe malaria, including infants and pregnant women in all trimesters, right? So that was a non-severe malaria that was given in the question in a first trimester, where you will choose quinine. Had it been a severe malaria, irrespective of trimester, and had it been a second or third trimester pregnancy, you would have chosen artesunate over quinine. That is important, and maybe they can just tweak this question for your next exam, right? So the answer is quinine. Next. Again, one of those very typical, exam-oriented questions, faggot sign is seen in. Now these questions, are kind of dated. Like I'll also be discussing something like drug-induced cholestasis, etc. I mean, initially these signs were described for a very handful of conditions. These are very old clinical signs. But now there are so many causes that you cannot actually, pinpoint and say that if somebody is having relative bradycardia, it's going to be enteric fever. It could be many other causes that can lead to relative bradycardia. Just discussing two important points over here. There's a Liebermeister rule, which is the basis for faggot sign. So Liebermeister rule is for each Celsius degree increase in body temperature above 38.3, corresponding rise in heart rate by 8 to 10 beats per minute is anticipated. So that's the baseline that you're going to expect. And what is faggot sign? The inverse of paradoxical relationship between body temperatures above 38.3 with a pulse lower than expected. So if the temperature is 102 degrees Fahrenheit, but the pulse rate has not increased by say 8 to 10 beats per minute, that is relative bradycardia. But you see, this is so vague, like unless somebody's spiking a fever of 103, 104, this difference is not going to be very significant, right? And you would have to know what's the baseline of this patient. The patient will come to you in a febrile phase, right? The patient will not come to you a febrile phase. You'll get the baseline pulse rate, and then the patient will not start spiking fever in front of you for you to, measure the change in pulse rate. So these are very dated questions, but yes, from the exam's perspective, it's enteric fever. But just to complete the list, these are the causes of relative bradycardia. Lots of organisms, infections can cause relative bradycardia. What is important for us practicing in India? You need to know about enteric fever, leptospira, rickettsia, and dengue fever, right? So these are important things that you should know about relative bradycardia in your differentials. Next question. Most common post-allogenic transplant infection after second month. Again, so this is an important question with an important concept. So this brings us to one of the most cited article by Tomlin et al. It's actually also called Tomlin's timescale for infections amongst allogenic stem cell recipients. So it is divided into three parts: phase 1, phase 2, and phase 3. Phase 1 is the pre-engraftment. Phase 2 is the engraftment, when the body is, when the transplant is engrafted, and then the late phase. So in the phase 1, so the patients are most vulnerable to hospital-acquired infection because there's a breach in mucosal integrity, the neutrophils are not there. So anything from the hospital, gram-negative, gram-positive organism, line-associated infection. Amongst viruses, herpes simplex is something that can, reactivate or cause an infection during the pre-engraftment phase. And of course, fungal species like Candida and Aspergillus, they are more commonly seen in the pre-engraftment phase. But what the question asked is beyond 30 days or the second month. So that is usually the early post-engraftment phase. In this, there's an impaired cellular and humoral immunity, but neutrophils, etc., they kind of come out. In this phase, so you'll see the second bar, this one. So this is the CMV. So this is the time where most commonly you can have CMV reactivation. Now, just to simplify this further, you can see there are three phases. There's a pre-engraftment, early post-engraftment, and late post-engraftment. You can see what are the immune system defects during these phases and the common infection during these phases. So if you look at the early post-engraftment, then CMV and varicella zoster, these are the common ones. Again, these are, like I say, in absence of antiviral prophylaxis. So most transplant patients would be on acyclovir prophylaxis, right, or valacyclovir to prevent herpes and varicella zoster. The general approach for CMV prevention in stem cell recipient is preemptive rather than prophylaxis. Again, we have discussed preemptive prophylaxis in details, but I'll just briefly cover them again. So in preemptive approach, we do not start antivirals, we just monitor CMV. And whenever it goes above a certain threshold, you can start the antiviral treatment. But again, this is now changing because earlier the issue was with the drug, valganciclovir. So nobody wants to give valganciclovir to a fresh transplant patient because it can cause, graft dysfunction, as in it can cause problems with engraftment, etc. But now with drugs like letermovir, the prophylactic approach is coming into play. So we'll have more and more data about it. But again, so once letermovir prophylaxis becomes standard of care in addition to acyclovir, then this the epidemiology of infection is going to change. As of now, we would still consider CMV to be the most common infection in the second month or just after the engraftment, right? So the answer here is going to be CMV. VZV, again, most patients will be on prophylaxis, plus herpes, etc., can even reactivate earlier than the second month timeline. Okay, this is another interesting question. Least common cells seen in TB pleural effusion. So again, this is kind of a googly. I mean, if you have read Harrison line by line, you would know that this is one of the lines in Harrison's. But the answer over here is mesothelial cells. So basically, the presence of mesothelial cells in pleural fluid of TB pleuritis is rare. Actually, what happens is that the intense lymphocytic infiltration covers both pleural surfaces, that is visceral and parietal pleura, and prevents mesothelial cells from entering the pleural space. And therefore, they rarely contain more than 5% endothelial cells. So we all know like neutrophils and lymphocytes. So the early phase of the pleuritis or pleural effusion may be dominated by neutrophils, which then become lymphocytic. Monocytes can be seen. In fact, Even peripheral blood monocytosis is one of the features of tuberculosis, which may be seen. The option that is correct over here is mesothelial cells because they are rare in TB pleural effusion. Next question is most common sign in infectious mononucleosis. Again, just taken up from Harrison's. But like I said, I really don't appreciate these kind of questions, but you have to mug them up. It's just this table where you see the signs are lymphadenopathy and fever. Now, if you see the difference between 95 and 93%, it's basically nothing, right? But based on the table, you just have to go for lymphadenopathy. Otherwise, just looking at IM, like infectious mononucleosis, it is characterized by fever, sore throat, lymphadenopathy, and atypical lymphocytosis. So if you consider, fever as a symptom instead of a sign, then the first two are symptoms. The third one is the most common sign, and atypical lymphocytes would be the most common examination finding or the investigation finding. Other important thing to notice, there are other viruses that can also cause IM-like illness, and the most important ones are CMV and HHV6, right? So these could be potential questions. Other than that, HSV1, HIV, toxoplasmosis, group A, beta hemolytic streptococcus, they can all cause infectious mononucleosis, but the most important ones are the CMV and HHV6. Okay, coming to our next question. A 50-year-old male was prescribed a common antibiotic for uncomplicated pneumonia. Later, he developed jaundice with raised bilirubin, raised ALP, and GGT. So the question is with respect to drug-induced cholestasis, right? Or drug-induced liver injury. Now, drug-induced liver injury can be three types: cholestatic pattern, hepatocellular pattern, or mixed type, right? If we just look at the cholestatic patterns of drug-induced liver injury, it could be acute and chronic. Amongst the acute, it could be cholestasis with hepatitis, without hepatitis, or with bile duct injury. And the chronic ones include non-specific bile duct injury, vanishing bile duct syndrome, and sclerosing cholangitis-like picture. Now, the question over here does not talk about symptoms. So we don't know if this is with hepatitis or without hepatitis, but it's definitely a cholestatic pattern. And if we look at the causes of, cholestasis or drug-induced cholestasis in general, there are more than hundreds of causes. I've tried to just highlight the important antibiotics associated with different patterns of cholestasis, and you'll see that amoxiclav figures in most. So we have amoxicillin, clavulanic acid in the options. That is going to be the right answer. But next time the question might be with different antibiotics. So you can just remember like macrolides, cephalexin, ciprofloxacin, clindamycin, and even Ceftra. These drugs can cause cholestatic pattern, although you need to know which kind of cholestatic pattern it causes. So the answer here is amoxicillin and clavulanic. Next question is image. So an image of a varicella zoster infection was given and some statements were asked. We don't remember or we could not recall all these statements with the question, but we have the right answer with us. That is, vaccinated are less likely to have atypical features than unvaccinated. So this is a false statement because vaccinated patients can have atypical kind of varicella. It's also known as breakthrough varicella. So it is seen in immunized individuals. It's very difficult to diagnose. Like I said, certain things are easy to read, but very difficult to suspect and diagnose. If we look at the incidence rates for single dose vaccines, it's 8.5 cases per 1,000 person years and 2.2 cases per 1,000 person years for 2 doses. The presentation may have very few lesions. They may not have vesicles. The condition is obviously less contagious than usual, and you might actually require PCR from the lesions to make a diagnosis. In fact, I was able to find out this picture from a CDC website. where they've talked about how difficult it could be just to diagnose atypical varicella. So this is like, so amongst all this image is a breakthrough varicella. But see, it looks so similar to insect bites or even scabies in children or herpes simplex. So it's difficult. You need to know about the vaccination history, past history of varicella, and then try to keep it in the differentials to be able to diagnose it. So with this, I think we come to the end of our discussion of recall questions. Maybe we have missed out on a few, but I think a lot of these questions or the concepts were actually covered in our classes. Although we had tried to, do a very, very concise review of such a huge subject, but still, I think we did cover a lot of questions and concepts in the classes. So I would suggest you can go back to the classes, go through them. There are lots of fine points or, between the line readings that I have suggested during the recordings. And I would strongly suggest that you go through them. Thank you. Hopefully you'll have a blast. Hopefully all of you have done very well in your exams. And people who are preparing for the upcoming exams, hopefully they'll do well as well. Thank you so much.